Hey everyone, welcome to today's live webinar, Different Dogs, Different Paths, Insights into Personalized OA Pain Management, sponsored by Zoetis. We're so glad you're here with us today. We also want to extend a warm welcome to our YouTube audience. I'm Dr. Cassie. I'll be your host and moderator for today's session. I'd like to cover a few housekeeping items with you before we begin. This session is being recorded and will be available this week as later this week as an on-demand course on Vetfolio for a limited time. If you registered on Vetfolio and you're attending this session live, no further action will be needed to obtain your CE credit. If you registered on YouTube, be sure to fill out the JOT form provided in the chat. You'll see your CE certificate in your Vetfolio learner profile within 24 hours. And with that, I'd like to go ahead and introduce our speaker. We're so excited to once again have Dr. Courtney Pierce with us today. Dr. Courtney Pierce received her undergraduate and veterinary degrees from North Carolina State University. She practiced small animal general medicine and surgery for 12 years before joining Zoetis in 2019. Her professional interests include soft tissue and laparoscopic surgery, pain management, and feline medicine. She obtained her MBA from King University in 2022 and is currently the medical lead for the pain portfolio at Zoetis. Dr. Pierce lives on a small farm in Damascus, Virginia, with her husband, 2 boys, and a variety of companion and farm animals. That sounds like my dream. Let me go ahead and hand it over to her, and we'll get into our talk.
Hello, I'm Dr. Courtney Pierce, and I am the medical lead for the pain portfolio at Zoetis. I did my veterinary training at North Carolina State University, College of Veterinary Medicine, and earned my MBA at King University. I have a passion for minimally invasive surgery and pain management, both in acute and chronic conditions. And as a veterinary student, I had the opportunity to work in a pain research laboratory where the work focused on validating a clinical metrology instrument known as the CSOM, or client-specific outcome measures, which is a tool now used to measure pain relief in cats with osteoarthritis. And through that work and years in clinical practice, I've become a passionate advocate for identifying pain early and intervening with effective therapies. Now, this discussion will focus on canine osteoarthritis pain, and we'll look at strategies for screening, diagnosing, and controlling OA pain using evidence-based approaches that consider the unique needs of the patients and their families. So I am thrilled that you've taken the time to join us for this learning, and let's go ahead and get started. So first, a review of our learning objectives today. We'll briefly review the mechanisms of osteoarthritis pain and the role that nerve growth factor plays in OA. While there are many factors that drive OA pain, nerve growth factor is a relatively new target for therapeutics, so we'll take a moment just to review this specifically. Next, we're going to explore strategies and best practices for OA pain control with an emphasis on expert guidelines because these provide a logical framework for intervention and therapy. And finally, we're going to discuss real-world cases of osteoarthritis where the treatment approach was anything but one size fits all. Now, you will notice that each of the cases features the use of Librela, and this is by design. As the medical lead for Librela at Zoetis, one of the #1 requests that I get is to share how this therapy fits into a multimodal approach to OA pain control. So by exploring 3 very different patient journeys with OA pain control, I'm confident you'll walk away from this hour with actionable insights to better serve your patients. So, all right, let's set the stage with some data about the current landscape of OA prevalence and treatment barriers in canine patients. OA, as we know, is a common painful condition that is estimated to affect approximately 20% of dogs a year of age or older. Now, other studies show a prevalence of osteoarthritis pain closer to 40% of all patients presented to veterinary hospitals. And while osteoarthritis is often assumed by pet owners and some veterinarians to be an old dog disease, Studies underscore the fact that osteoarthritis is not exclusively a disease of older dogs. In fact, one recent study from North Carolina State University demonstrated that nearly 40% of dogs less than 4 years of age have radiographic evidence of osteoarthritis in greater than one joint, even in the absence of clinical signs. So let that sink in. Dogs less than 4 years of age, 40% of them have radiographic signs of osteoarthritis. That blew me away and changed the way I approach osteoarthritis pain. And despite the impact that OA has on a dog's quality of life, it is a real challenge for pet owners to recognize when their pet is suffering from this condition. And once OA is diagnosed, many owners find compliance with pain control to be challenging. A recent study found that nearly half of surveyed dog owners were non-compliant with medication instructions, and approximately a third of dog owners reported challenges in giving prescribed medications. So additionally, we have data that shows nearly 25% of dogs with OA pain are not diagnosed. And that means that a fourth of patients with osteoarthritis pain never get a diagnosis, let alone treatment. So while OA is an incurable disease, no matter if we diagnose it or we don't, a dog's quality of life can be improved significantly with effective pain control, especially when it's introduced early in the stage of the disease. So what that means for us as veterinarians and veterinary healthcare providers is that performing regular screenings and educating owners on the signs of pain are important with helping that diagnosis be achieved early on in the course of the disease. So as I mentioned, we're going to take a look at the role NGF plays in osteoarthritis pain. And we're doing that because the newer therapies for osteoarthritis pain in companion animals target this protein. NGF, as a reminder, is produced by damaged tissues in the affected joint. Once it's released, it binds to its receptor and initiates pain signaling in both the peripheral and the central nervous system. Further, it causes the release of pro-inflammatory mediators from immune cells and nerve endings. NGF creates this feedback loop that leads to central sensitization, neurogenic inflammation, which is actually inflammation released from nerves, and neuronal sprouting. So with just this brief overview, excuse me, you can see why NGF is an attractive target for controlling OA pain. By preventing NGF from binding to its receptor, the cycle can be disrupted. Peripheral and central sensitization is prevented, and inflammatory mediators are not released from these immune cells. And then additionally, neuronal sprouting can be limited in those already painful joints. So let's take it a step further and explore how monoclonal antibodies have been engineered to achieve this goal of disrupting this cycle. As a reminder, monoclonal antibodies are antibodies that have been designed to bind and inactivate specific target molecules. And because they are highly targeted, mAbs can be designed to be species specific, which limits the immune response. Additionally, off-target effects are reduced by the specificity of monoclonal antibodies. Anti-NGF monoclonal antibody therapy for the control of OA pain uses monoclonal antibodies designed to target this pain mediator NGF. And by binding to it and blocking it from binding to its receptor, we thereby reduce pain signaling and break that NGF cycle. So as many of you are likely aware, Librela, benvetmab injection, is the only anti-NGF mAb approved for the control of OA pain in dogs. Librela is a monthly subcutaneous injection administered by veterinary professionals. It provides month-long control of OA pain by binding to excess NGF that is present in dogs with osteoarthritis. Now, Librela has been approved for use globally for almost 5 years, and in the US for almost 3 years. To date, over 30 million doses of Librela have been delivered worldwide, So while certainly not a new option for OA pain control, I do want to review a couple of key points regarding Librela before we move on. So it is critical that a veterinarian establishes a diagnosis of OA and determines that a dog is a good candidate for Librela. Once that occurs, as I mentioned, it is administered as a monthly injection. Just a reminder that Librela is not for use in any other painful conditions, including acute pain, or as a substitute for surgery. It is for the control of osteoarthritis pain only. Now, with that, Librela has been shown to be safe and effective for the control of canine OA pain while helping to improve mobility and quality of life. And I want to reiterate, Librela provides month-long continuous pain control for dogs with OA. And why is this important? Well, we just talked about a study that found 47% of dog owners were non-compliant with medication instructions. And approximately 1/3 of them reported that they were having challenges with medications. So you can imagine why they are non-compliant. And while OA is a progressive and incurable disease, the dog's quality of life can be improved significantly if we intervene with effective pain control, especially at early stages of the disease. So it's important that these therapies are given. And Librela has been used in a wide range of canine patients with different severities of osteoarthritis, from mild to moderate to severe. So just another minute on compliance. Again, we know osteoarthritis is progressive, it's chronic, it's incurable, but the pain that it causes doesn't take a day off. And pet owner compliance is a barrier to consistent pain control. And although NSAIDs are an effective treatment option for the control of OA pain, compliance with once daily or twice daily administration of nonsteroidal anti-inflammatories is often a challenge for pet owners. On average, dogs with osteoarthritis pain that are treated with nonsteroidal anti-inflammatories get only 60.5 days of therapy every year. So right around 2 months, typically not given consistently, but rather intermittently. And by comparison, current data that we have around Librela shows that almost 6 injections per year are administered to pets with osteoarthritis pain. Now, that's certainly not perfect. Ideally, pets with chronic pain would receive chronic therapy, but it is providing more pain control for pets that need it. And once we get into our case discussions, I will ask you to consider that in addition to picking the best therapy for the patient, it's critical that we consider the burden that our chosen therapy places on the caregiver. And ultimately, choosing a plan that is likely to be adhered to is important for overall success. So, a brief moment to pause for important safety information regarding Librela. Let's explore now strategies and best practices for OA pain control using expert guidelines that give us a logical framework for intervention. What you see before you here are the 2022 AHA pain management guidelines, and I would encourage you to read them in their entirety, as there is a tremendous amount of information. These are available online. You can simply search for the AHA pain management guidelines. And what you see here is a summary of both pharmacologic and non-pharmacologic interventions for chronic osteoarthritis pain. The first highlight I want to make here is that once osteoarthritis pain is diagnosed, it's essential to introduce effective, appropriate, and continuous pain control to reduce inflammation and prevent or lessen the effects of central sensitization. You can see that nonsteroidal anti-inflammatory drugs and anti-NGF monoclonal antibodies are recommended as first-tier treatment for all stages of osteoarthritis. Non-pharmacological interventions that are considered first-tier include omega-3 fatty acid supplements, exercise, weight optimization, and surgery if indicated. Now I want to take a second to draw your attention to the icons on the bottom of the screen. The therapies in Tier 1 are recommended based on their proven efficacy, their impact, which you see in that bottom right, it's sort of the arrow moving upward, and a lesser burden on the pet caregiver. So where you see the little person icon, that indicates potentially a high pet owner burden. And so the experts have told us that the approaches in Tier 1 are where we should focus because they are proven to positively impact the pet and are more likely to be adhered to through a lack of caregiver burden. But I want to be real for a minute here, because if we look over at Tier 2 and Tier 3 therapies, that's where we oftentimes recommend our patients start their OA pain control journey. We recommend non-omega-3 supplements like glucosamine and chondroitin, which the guidelines state, and I quote, have little evidence to support their analgesic effect. Or in Tier 2 with gabapentin or polysulfated glycosaminoglycans, which I quote, have little or mixed evidence of efficacy and are recommended to be used in addition to Tier 1 therapies. So just pausing for a moment, as a profession, based on expert guidelines, when it comes to control of chronic osteoarthritis pain, we're working backwards. We're oftentimes reaching for therapies that seem easy, but in reality do not carry the weight of efficacy that first-tier therapies do. And I believe that the number one goal of any OA pain treatment protocol must be to alleviate pain effectively so that the patient can engage in exercise to optimize weight and maintain muscle mass and flexibility. Interestingly, one study showed that just a 7% reduction in body weight for a patient had a noticeable improvement in their OA pain control. That's without pharmacological intervention. Just weight loss can make a huge difference. But I also think it's the case that pets that can't exercise comfortably really struggle to lose weight, even with calorie restriction. So food for thought here. Let's work starting with Tier 1, moving to Tier 3 therapies, rather than starting backwards and only intervening with effective therapies when other things that we have evidence to say won't work, don't work. Okay. So we're going to get on to hypothetical patient Lucy here. You can see she's a patient that would be likely to walk into your veterinary hospital. And if we consider the statistics, about 40% of those patients are going to be suffering from OA pain, and we're going to miss about a quarter of them. So let's pretend Lucy arrives at your hospital for a wellness exam. She would ideally undergo screening for osteoarthritis at this point. Now, how many of you are routinely screening for OA pain in 5-year-old dogs? I won't make you answer because I have a feeling that I know what you'll say. But what if we could make it easy? What if it took less time to do this than it took to run a heartworm test and was free to the client? Would that make it more likely to happen? I think so. So here it is. If you haven't seen this before, this is called the OA checklist. It's a helpful tool to walk through with owners to help them recognize the signs of osteoarthritis pain and give you valuable insight to your patient's behavior before they get to the veterinary hospital, when adrenaline takes over. And it's like bringing your car to the mechanic. It doesn't make the noise. It doesn't do the thing that you brought it in for. So it takes less than 2 minutes to complete. I've timed it. And though positive responses to these questions in this checklist are not specific for osteoarthritis pain, any check in the affirmative, such as lagging behind on walks or difficulty jumping into the car, warrants a deeper investigation. It raises our clinical suspicion that there may be osteoarthritis pain present in this patient. So I'm going to ask you to scan this QR code here so that you can access the OA checklist. These can be printed out, laminated, or offered to the client in a digital format for them to fill out before they come to the hospital, or perhaps while you're running the sample for their heartworm test. Give them this and let them spend just a minute completing this so that you have more information. Now, going back to our hypothetical patient, Lucy, let's say that her owners checked that she's been lagging behind on walks and has been just a little bit hesitant to climb the stairs or jump into the car. So once you've discovered that, the next step then would to be assess or do a physical exam thoroughly on Lucy. Now, again, we have another resource here for you. I'll load the QR code so you can scan this. This helpful exam guide takes you through an orthopedic exam step by step. You can print this out. Again, you could laminate it for reuse. And it walks you through all the components of a physical examination with an orthopedic focus. Now, again, I know some of you might be thinking, I only have 15 minutes. I'm not doing an orthopedic exam. I hear that all the time. And I know from years of experience that you can incorporate a simple but effective OA screening during a routine physical exam. I'm a general practitioner. I have many goals when I walk into a room with a patient. So I'm not talking about the exam you watched your orthopedic surgeon professor do when you were on your clinical rotation in vet school. I mean a brief hands-on evaluation, ideally coupled with a gait evaluation. It can be done in under 6 minutes. I can do it faster than that. I would say 2 to 3 minutes. I can get a pretty good sense of where the patient stands. And again, because I suspect you don't believe me, I'm going to ask you to scan this QR code, both to download this form and to see for yourself a renowned orthopedic surgeon, Dr. Ross Palmer, walk through a basic ortho-neuro screening in under 6 minutes. And you can use that video to guide your own examination. There's some really great pointers in there. It doesn't come without practice. I've been doing this for almost 2 decades now, so I have it down to a science. But with a little bit of practice and a little bit of focus, you can get there too. So let's say during your orthopedic focused exam, you notice that Lucy has a decreased range of motion in her hips and maybe a little bit of pain when you extend her hips. So the next step is going to be, of course, for Lucy or any other patient with clinical signs of osteoarthritis pain, is a diagnostic workup. So you're going to recommend radiographs, most likely at this point. Certainly we could get into MRIs for more complex conditions, and then ideally blood work to assess her overall health. And because you did her orthopedic exam in the room with the owner has now observed that Lucy or any patient with OA pain sort of resisted some of the movements that you were doing or showed obvious signs of discomfort. Now the owner, coupled with the check on that OA checklist, is going to be a little more receptive to the idea that Lucy might be in pain versus just slowing down or this being her normal behavior. So one more resource here to share at this point. I know I made it sound simple. I made the screening, the assessment, and the diagnosis sound simple, and I know realistically it's not. This QR code here will lead you to a free CE course worth 3 race credit hours that walks through from observation to diagnosis, everything I covered in the last couple minutes, but in a really comprehensive way. And that CE course is absolutely phenomenal. I've taken it myself. It really helps us to learn or refresh our skills with that process. So feel free to explore that learning as well. So now you have screened Lucy for OA pain. You have assessed her with a physical examination. Let's say you see signs of osteoarthritis on the radiographs that you have obtained. Step 4 will be to control the pain that you found associated with osteoarthritis. But I'm going to ask you here to take a pause, because at this moment with the presumptive diagnosis of osteoarthritis, initiating pain control is indicated. But let's also take a moment to pause and consider what other conditions may be present, such as neurologic disease, surgical conditions that are correctable, or anything else that may be there. So yet another resource for you. Scanning this QR code will lead you to a wonderful, again, CE opportunity that goes over distinguishing orthopedic abnormalities from neurologic abnormalities, because we know this is one of the most challenging aspects of what we do day in and day out when evaluating gait and mobility challenges. Now, our hypothetical patient, Lucy, is 5 years old. But in reality, a lot of the patients that we're initiating therapy for osteoarthritis pain tend to skew towards an older age. And older dogs, we know, have a higher prevalence of neurologic abnormalities and oftentimes overlap between orthopedic and neurologic disease. And it is important for us to have a certain diagnosis, or at least a relative certainty of our diagnosis before initiating therapy. So again, resources to help guide your diagnostic approach and your therapeutic approach. Oh, so let me back up just one step there. Let's say that you determine that Lucy has osteoarthritis pain. You could consider prescribing Librela at this point. You've confirmed your diagnosis with a physical examination, ideally with radiographs, and you've had a discussion with the owner about the disease state of osteoarthritis, and you're making a treatment decision. So now we're going to refer to our AHA pain management guidelines. We're going to choose one of two first-tier therapeutic options, and we're going to support that with non-pharmacological intervention like omega-3 fatty acids, weight optimization, and controlled exercise. Non-steroidal anti-inflammatories are also a choice of treatment at this point, with consideration of ensuring that treatment is initiated in a continuous fashion, because we know Lucy's pain isn't taking a day off. So again, there's that resource for distinguishing ortho versus neurogait abnormalities. And now, once we've initiated a treatment plan, we've discussed repeatedly that weight optimization is key to the overall management of osteoarthritis. Dogs with a lower body condition can have alleviation of some of the pain caused by osteoarthritis simply by reducing their weight. We also know that controlled exercise is critical in maintaining muscle mass and flexibility and keeping these patients moving. So what we have before you here, along with associated QR code for you to scan, is what's called the Back to Play guideline. This is a step-by-step program that you can share with pet owners. Once you've initiated pain control, we don't want these patients going from couch to 5K in one day. It should be a gradual, controlled process. We think about these patients who have maybe been inactive or less than active for months or even years. They don't have the muscle mass and the flexibility to support a sudden return to full movement. Yet, oftentimes in their minds, they say, I feel great. I'm going to get right back to running across the yard or chasing squirrels. And that can lead to soft tissue injury or even worse. So these controlled return to exercise guidelines can be given to pet owners to support that return to healthy play. So make sure to grab that resource and share with your pet owners where you're initiating therapy. So now we've walked through a hypothetical patient, Lucy. We've arrived now at our case studies. So we're going to walk through a couple of patients where they have gone through a journey of screening, diagnosis, treatment initiation, and follow-up. So we have before you our three patients that we're going to take a deeper look at now. So starting with Maddie. Maddie is a real patient, and all of the information for Maddie and our other two cases are accurate per owner and medical records. Maddie happens to be my patient and one of my very favorite girls. She is a total sweetheart. So we're going to start this case when Maddie was 13 years old. Maddie is a Beagle Labrador mix, and I've been caring for her since she was a puppy, but we're going to start at 13 years old. Maddie's list of comorbidities is extensive. It includes mitral valve insufficiency with congestive heart failure and Addison's disease. Now, both of these conditions are currently well managed, but she's certainly complex. She's also 13 years old, so fairly advanced in age. Maddie is taking 6 different oral medications along with 1 injection monthly for control of her Addison's disease. Additionally, her owners give her a glucosamine and chondroitin supplement that they sourced online. In addition to her two systemic diseases, Maddie also has a history of left cranial cruciate ligament rupture when she was 7 years old that was repaired with a TPLO. Ultimately, she had her TPLO hardware removed, but she did have that leg surgically corrected. And because of her medical history and the fact that Maddie is just an absolute princess, her owners bring her to the veterinary hospital for wellness visits consistently, in addition to visits for control of her comorbidities, and are truly eager to give her the best care. These are the types of owners that we all want to work with. So again, at age 13, Maddie came in for a pretty routine visit. During this particular visit, the following was noted during her physical exam. She weighs 42 pounds. She's a little bit on the chunky side. We scored her at a 6 out of 9. Now, the owner, with appropriate history taking and OA checklist administration, did note that she was slowing down a little bit, but she was still getting around okay. On gait evaluation, it was noted that her gait was pretty stiff. And in her rear limbs, I can palpate crepitus in her left stifle, pretty much have been since she had surgery. She had blood work done at the time as part of her senior assessment and medication monitoring. And due to her stiff gait and history of a TPLO, I discussed possible osteoarthritis, probably not for the first time with these owners, as well as treatment options. And it was stressed to our owners that this concept of slowing down is not simply a normal part of aging. It can be and likely is a sign that Maddie is in pain. We discussed switching to fish oil rather than glucosamine and chondroitin based on evidence that we have for efficacy. And we discussed, again, probably not for the first time, trying to get Maddie to shed a few pounds. Now, I will say it's always been a challenge for Maddie because she's a Beagle Lab mix on steroids. You've never met a hungrier dog than Maddie. We also discussed more definitive tier 1 therapy for OA pain, but our owners were a little hesitant at the time to add more medications, which I think we can all appreciate. They have 6 oral medications to give this dog on a daily basis. So now I want to pause here, because I knew at this visit that Maddie was suffering from OA pain, but truthfully, we didn't start any additional therapy focused on OA pain here. We talked about switching her supplement to omega-3 fatty acids. Does that mean I'm a bad vet? Does that mean that Maddie's owners are not good? I would say no. I didn't sugarcoat things with them, but I understood that we needed to give them a little bit of time to digest and to observe Maddie at home now that we had planted this seed about what the next step might be for Maddie. And I think this is a realistic case. These owners are top-notch. They're managing multiple medical conditions, and they're willing to do what's best for Maddie, but they just needed a little bit of time. So what happened next? Well, Maddie returned 2 months later because her owners were noticing more of the signs of pain that we had discussed and that they had seen on the checklist. She was slow to rise. She was reluctant to go upstairs, and they started to appreciate that she had a stiff gait in her rear limbs. They did go ahead and start fish oil supplementation, but we're still working on her weight. And at this time, they were more committed to looking at more options, or looking at options for treating her pain. But I feel like they needed a little bit of time to confirm that this was the right step for Maddie. I do want to make a note that at this visit, we did discuss taking radiographs to confirm the diagnosis and rule out other issues that could be causing the clinical signs. And while Maddie is a very well-tempered dog, for Maddie, sedation was going to be necessary to get appropriately positioned orthopedic radiographs. And due to her heart failure, which is well controlled, the owners were just a little reluctant to do sedation for the x-rays. So again, I want to point out the reality. I would love x-rays of Maddie, but we decided to move forward with a presumptive diagnosis of OA based on physical exam and clinical signs. And Maddie has been radiographed in the past, so I have no concerns about making a presumptive to definitive diagnosis of osteoarthritis in this case. So I'm going to show you a video now of Maddie's gait pre-treatment. You can see that her gait in the hind limbs is pretty stiff and stilted. She doesn't have full extension of those pelvic limbs. I would also note that her front limbs are quite stiff. So you can see Maddie has some pretty significant trouble getting around and ambulating. I will also note that I happen to know there was some catering in the back of this vehicle for a party that was happening. So this Beagle Lab was pretty motivated to get to that food and maybe walking faster than she normally would otherwise. So because of Maddie's medication load and her Addison's disease, her owners were really worried about adding more pills. Further, we know patients with Addison's disease are managed with what we sort of assume is a physiologic dose of steroids. But the reality is we don't know for each patient what the ideal physiologic dose is. So mixing a non-steroidal first-tier therapy with steroids is not in the cards for Maddie. So the decision was made to start Librela injections once a month for management of her OA pain. The owners were advised to continue fish oil supplementation to try to manage her weight, to optimize it. And they were given the back to play instructions with strict guidance to balance her activity, which typically isn't a challenge for Maddie. And so let's look at her post video. This was about 2 weeks after she received her first Librela injection. And unfortunately, the substrate she's walking on is different than what we saw in the initial video. But I would almost argue that this is a little bit more challenging substrate than grass. And you can see that her gait is much smoother. She's got a little bit less stiltedness and hesitation to walk. And the owners appreciated all around at home that her gait was better. She was able to get up and down the stairs. You can see in the background there that their house has a serious number of stairs to get in and out of. So at that point, the plan was made to continue using Librela monthly in conjunction with all of her medications. So now we're going to fast forward a little bit because Maddie is now almost 15 years old, and she's been on Librela monthly since that initial visit. She has had a positive response to Librela and has tolerated it very well. However, we know osteoarthritis is a progressive disease, and Maddie at this point is experiencing increasing stiffness and decline in activity due to the progression of her disease. But Maddie's owners truly appreciate the difference that Librela has made for her over the past 2 years. Now, with her disease progressing, there is discussion and implementation of at-home physical therapy. So in an ideal world, she would see a rehab specialist. Her owners live quite far, and that is the reality for many pet parents. They are far from that type of therapy, but they are instituting or have instituted at-home physical therapy, including range of motion, massage, and appropriate heat therapy. Gabapentin has been discussed as an adjunctive therapy, but they had a previous pet that had some ataxia on gabapentin, so they are reluctant to start Maddie on gabapentin, but we may revisit that. They are also looking at mobility assistance devices, which fall into that tier 3, according to the AHA pain management guidelines. We're not at that point yet, but it is on the table. Overall, her owners are very happy with her therapy and they are looking forward to celebrating her 15th birthday. So, just a pause for a moment to consider if Maddie was your patient, would you be recommending other interventional therapies? Would you have approached this case a little bit differently? I think looking back, frankly, I would have intervened a little bit sooner with a tier one therapy, but options for Maddie were limited early in the course of her disease because of her need for daily steroid therapy. So that was Maddie. We're going to move on to a different type of patient or a different patient. This is Ernest Ham Biscuit. Yes, that is his full name. And no, I do not know why he is named Ernest Ham Biscuit, but it's quite cute. So Ernest has significantly less comorbidities than Maddie, our first case. But he's still going to be quite interesting, as you will see. So Ernest is a 9-year-old neutered mixed breed dog, mostly a beagle. He was adopted from a rescue as a puppy. And when he was adopted, he was, a happy, energetic, normal puppy, fit into the household perfectly. But it wasn't long after he was adopted that his owners noticed a little bit something peculiar about Ernest's behavior. They noticed that unlike other dogs that they had, Ernest, even as a young puppy, would sit down frequently, which is kind of an astute observation, but they just thought he was quieter than normal. So Ernest's OA journey is going to start very early, kind of at the opposite end of the spectrum of Miss Maddie. When his owners noticed that he was reluctant to play with his housemates and would kind of sit and stop on walks or as he was playing, they presented him to his veterinary clinic. And a little behind the scenes here, Ernest is owned by a veterinary professional who works in a vet hospital. And at that hospital, they performed pen hip evaluation. So it was suggested that Ernest have a pen hip evaluation because he was showing some signs of pain bilaterally in his hips. So for those of you that may not be familiar with pen hip, it's one diagnostic modality that can be done to assess the coxofemoral joints. And particularly with the pen hip, a distraction index is calculated. So the x-rays are taken using a special piece of equipment that actually gently distracts the femoral head from the acetabulum. And based on that amount of distraction, a score is generated that can be predictive of a future potential for developing osteoarthritis. And as you can see with Ernest's pen hip report here, he was determined to be at a high risk for the development of osteoarthritis based on his distraction index. Very simply said, Ernest had hip dysplasia. At the time that the pen hip diagnostic test was done, Ernest's owner were advised to keep him at a healthy weight, start fish oil therapy, and recheck frequently. And that's what the owners did. By 4 years of age, Ernest was starting to have significant mobility limitations. His symptoms were progressing. He was less likely to run and play with his housemates. He was demonstrating pain in his hips and bilaterally in his carpus because, a little bit of spoiler alert, Ernest also has bilateral angular limb deformities. So he doesn't really have a good end. He's got like a bad end and a worse end. So at 4 years of age, the owners did another assessment for his mobility conditions. They also noticed at that time, or noted at that time, that Ernest was demonstrating changes in his behavior. He was becoming somewhat aggressive when asked to move off a piece of furniture. And though the owners somewhat chalked that up to like his attitude, they were concerned that it was a sign of pain. So at this visit, Ernest was started on a daily non-steroidal anti-inflammatory medication, which was carprofen at 2.2 milligrams per kilogram twice a day. The owner was advised to continue to optimize his weight, continue with omega-3 fatty acids, And that was the treatment plan for him at that time. So you can see a summary of his visit here. He did have bilateral pain on manipulation of his carpi, pain on hip extension. He did have some mild atrophy of quadriceps and hamstrings, and he demonstrated a classic bunny hopping gait, which you're going to see. Thankfully for Ernest, his body condition is pretty optimized. His owners keep him thin and fit because kind of from day one, they've known that that was going to be critical to maintaining the best quality of life possible. So again, as a reminder, at that time, long-term non-steroidal anti-inflammatory medications were prescribed to manage his pain. These are tier 1 therapies. And the goal was just to continue to support Ernest to keep him as pain-free as possible so that he could keep moving, stay flexible, maintain his muscle mass, and his quality of life. Ernest's radiographs are here for evaluation. You can see pretty distinctly that he has an angular limb deformity. That left carpus is quite bowed. On the right-hand side of the screen, you see his hip x-rays. Now, I've certainly seen worse hips than Ernest has, but you can tell he has shallow coverage or shallow acetabulum with less than 50% coverage of those femoral heads. Interestingly, we know dogs that have angular limb deformities oftentimes have incongruity or do have incongruity in the joints above and below the angular limb deformity, which can lead to osteoarthritis. And we see that pretty clearly here in Ernest's right and left elbows. He does have signs of osteoarthritis in those elbows. So again, he's kind of got bad limbs and worse limbs. Poor little guy. The next thing I'll show you here is a video of Ernest. He has a classic bunny hop gait. So you can see he keeps both of his pelvic limbs together as he runs. And that is classic for dogs with coxofemoral osteoarthritis or hip dysplasia. So pretty classic bunny hopping gait there. Now, an update on Ernest's case here. So he was originally started on daily non-steroidal anti-inflammatory therapy. At 6 years of age, Ernest was presented because he just wasn't doing that well. The owner felt like he could do better. He was continuing to decrease his activity. He had a little bit more withdrawal of his personality, and they felt like his aggression was increasing. He was also having trouble jumping in the car, which was one of his favorite activities, to jump in the car and help bring his human children to school every morning. So the owners came in wanting to discuss additional therapeutic options. They also, at this time, acknowledged that they had been somewhat inconsistent with the non-steroidal anti-inflammatory therapy and the fish oil supplementation or omega-3 fatty acids. They were also struggling a little bit to limit his activity, and this is, somewhat of a reality for many pet owners. Rather than leash walks, they were letting him out with the other dogs in the household. As a veterinarian, it was also, or the veterinarian stressed to the owner that some of these interventions were going to be critically important to keep Ernest healthy and active for a lifetime, specifically consistent pain control. So at that visit, it was discussed, or Librela was discussed as an alternative pain option to the daily non-steroidal therapy. And the owner was willing to consider this because they felt that a more consistent therapy that was not dependent upon twice daily or even once daily administration would fit better into their busy household. So at that time, non-steroidals were discontinued. Librela injections were started once monthly. The owners recommitted to controlled exercise, and they sought a prescription diet with omega-3 fatty acids, again, to reduce the caregiver burden of omega-3 supplementation. Thankfully, again, his body condition score was still fabulous, and they were encouraged to continue to optimize his weight. 3 months following the initiation of Librela, his owners noticed that his aggressive behavior had resolved. His mobility and muscle mass had improved slightly, and he was a little bit more interactive with the family. 24 months after initiating Librela therapy, Ernest is still doing well with no adverse effects noted, aside from maybe complaining a little bit. He is a beagle after all, so with each injection, he lets us know of his discomfort. This case underscores our previous discussion around compliance. The pet caregiver here is knowledgeable about his condition and has been pretty well looped in from early in life, but they also have a very busy life and have struggled with compliance. So Librela in this case has offered Ernest's family assurance that his pain will be controlled in a continuous fashion. So for Ernest, they plan to continue the Librela therapy, weight optimization, omega-3s, and controlled exercise. They're also going to recheck frequently, again, because we know osteoarthritis is a progressive disease, and changes to his treatment plan may happen over time. So finally, our third case is Wyatt. And who doesn't love a little kitty? Wyatt is 9.5 years old. He was born with some orthopedic misalignments. He's a little bit bow-legged, but certainly didn't slow him down for the majority of his life. He's very high energy. He has one little pitty housemate named Josie, and he's very active and loves to play with her. As a puppy, Wyatt injured his left foot, so he has a little bit of a valgus positioning of the foot, but it didn't seem to slow him down, and it has worsened a little bit over time, but it's not considered to be the main challenge for Wyatt. At 6 years old, Wyatt ruptured his first cruciate ligament during a fight with his housemate. They play pretty actively. At that time, his veterinarian or his veterinary surgeon performed a TPLO to stabilize the joint and prescribed him a non-steroidal anti-inflammatory drug, both peri and post-operatively. So again, just a reminder here that cruciate ligaments are best repaired with a surgical intervention. His owners did continue to give non-steroidal anti-inflammatories following his surgery, sort of on an as-needed or intermittent basis if they noticed that he was having, what they described as a painful day. Then, as you might imagine, 2 years later, Wyatt ruptured his left cruciate ligament walking down the stairs. So he had a second TPLO, and his owners continued again to manage his pain with a non-steroidal. So this case is going to highlight first-tier therapy of surgery for cruciate ligament ruptures. That is the recommendation. And I borrowed this case actually with permission from an orthopedic surgeon. And the important note here is that for dogs with a cruciate ligament rupture, this qualifies as an exciting event that will, not if, but will lead to the development of osteoarthritis. So according to this surgeon and many, and I think all of us, a thorough post-op TPLO discussion includes a commitment for long-term monitoring, weight optimization, and frequent screening for osteoarthritis pain. And that happened here with Wyatt. So just some beautiful TPLO rads for you all to view. Pretty standard repair that Wyatt underwent. Following surgery, a controlled exercise plan was developed using the Back to Play guidelines, and the owners were encouraged to keep Wyatt at a reasonable body condition score. Now you'll see that that wasn't necessarily achieved, but we all know that pitties like their snacks as well. They were advised to start a fatty acid supplementation, and orthopedic exams were recommended every 6 months to monitor for signs of osteoarthritis pain and for the owner to complete this checklist. Again, the surgeon was pretty straightforward with them. They expected that Wyatt would develop osteoarthritis following his 2 TPLOs, his cruciate ligament ruptures, and they wanted the owners to be on the lookout for signs of compromise. So sure enough, 1 year later, Wyatt is 9 years old, and now when his owners fill out this osteoarthritis checklist, they note that he's lagging behind on walks, he's slow to rise, and he's having some difficulty with stairs. His physical examination showed a decreased range of motion in his stifles, pain on flexion and extension, and thickening of the joint capsule. Interestingly, Wyatt also has pain on manipulation of both elbows with reduced range of motion. So yes, we're fairly certain he's going to have osteoarthritis in his stifles, but we don't overlook other joints that may be affected. So you see radiographs of Wyatt here, his 2 TPLO surgeries and bilateral elbow rads. You can see that Wyatt, I don't know if I had to pick a better or worse joint, I might say the stifles look better than the elbows. So at this point, Wyatt's owners are concerned that his osteoarthritis is impacting his quality of life, and I would agree. Again, these are busy pet owners, so a discussion was had with them about therapeutic options that are tier 1. And the owners ultimately did choose Librela therapy. They have had him on Librela for about 3 months now and have noticed a distinct improvement in his mobility and quality of life. This was a good choice for his family, again, because they're busy and they wanted consistent therapy. They've struggled a little bit with his weight control. You can see he's kind of shaped like a potato in this picture, but they are working on it. One additional note here, so we've gone with tier 1 therapies of Librela. In the past, he had nonsteroidal anti-inflammatories, weight optimization, and omega-3s. The owners are also in discussion about single joint injections for his elbows. So tier 3, but certainly considered reasonable adjunctive therapy for pets with fairly severe chronic osteoarthritis of multiple joints like Wyatt has. So they're really optimizing his quality of life to the best of their ability. So with that, those were our 3 clinical cases for evaluation. I want to share with you just some summary points and what we would call an action plan here. So first, 3 clinically relevant pearls. Considering osteoarthritis pain earlier can help patients in the long run. We think about our clinical cases and how early Ernest had intervention in his life. It's kept him active, it's kept him slim and trim and doing well. And we contrast that with Maddie, who had intervention a little bit later in life, and she's, struggling a little bit more. Second clinically relevant pearl. Librela has been shown to be safe and effective for the control of canine OA pain while helping to improve mobility and quality of life. It is a first tier therapy choice among other therapeutic choices, but I hope that seeing how this therapy has been incorporated into an overall multimodal treatment plan for a few patients has been illustrative for you and will help you clinically. And then lastly, OA treatment plans should be tailored based on the patient's health and lifestyle. And I would say owner capabilities is a huge one here. Owner caregiver burden is an important consideration and will lead to the relative success or lack thereof when it comes to a treatment plan. 2 questions for you all to consider. How can you identify pain in your patients sooner? It's imperative that we commit to this goal, and the OA checklist is a very simple way to do this. And what resources would make this process more efficient for your teams? I hope you've captured all of the resources that I've shared. You can always visit zoetis.us.com, where we have all of those resources available to you. And then finally, one action for you to take. I would love it if you would introduce all dog owners, not just those that you have suspicion for, the canine OA checklist. I would love for you to perform orthopedic screening exams and have open conversations to recognize the signs of OA pain earlier. So with that, I would like to thank you for joining us for this time, and I will take whatever questions you may have.
All right. Wonderful. Thank you so much. What a great talk there. Lots of great questions coming in. And I just want to acknowledge here, we'll get into some of these questions. We have a little bit of time here, but to be respectful of everybody's time, if you're attending, say over lunch or something like that, I know we're at 1 o'clock. If you need to go back to the clinic floor or whatever you need to do, absolutely. Thank you for joining us. You'll get your CE credit. No worries there. And really appreciate everybody's time. Dr. Pierce, thank you. That was wonderful. And I saw you kind of answering some questions along the way. Do you have a few minutes to spend some time elaborating on a couple of them?
I do, Dr. Cassie, and I was just about to answer one regarding concurrent administration of NSAIDs with Librela. If you want to start there, I had just moved it over to the answer feature. So would it be okay if I started with that one?
I do, yeah, because I saw that one come in a couple times. So I think that's a great place to start.
Okay. Well, yeah, thank you. I did answer it, I think, for another one of our guests early on during the presentation. But I think it's a really important question because as veterinarians, we're trained, rightfully so, to approach pain management multimodally. So using medications or therapies that have different mechanisms of action. And we know that nonsteroidals and Librela have a different mechanism of action. So a couple of thoughts there around concurrent administration. One is that while we do have a short-term co-administration with Librela and carprofen, that study was 2 weeks, and it was conducted in healthy laboratory animals. And while there were no significant adverse events associated with co-administration, it's really not truly enough information for us to draw a conclusion that long-term safe co-administration is warranted. Now, I would offer up another thought, though, which is that when we're looking at pharmaceutical intervention, yes, it's great to do multimodal management, but I put a link to a paper where patients in the EU that were receiving Librela, 75% of them, that was the only analgesic tier 1 therapy they were receiving. So kind of what I draw from that, and with my own patients, is that Librela can be a standalone when it comes to pain. And if we're looking to add other therapies, we can look at tier 1 non-pharmaceuticals, so omega-3 fatty acids, exercise, weight modification, or optimization. We don't necessarily need to pair it with a non-steroidal. And if I may, just one more thought, because I get this question all the time, and it's, well, I need to treat the inflammation of osteoarthritis. So I think as veterinarians, we really want to put a non-steroidal anti-inflammatory in there. And two considerations. One is that based on the mechanism of action of Librela, if you think back to the beginning of the talk, it actually does have significant impact on inflammatory pathways. NGF stimulates the release of pro-inflammatory mediators, neurogenic inflammation. So when we disrupt that process, we are disrupting inflammation. Additionally, osteoarthritis is not a hot disease. Despite what some will tell you, some people refer to it as cold inflammation. It is chronic. It is not immune-mediated polyarthritis. It's not rheumatoid arthritis. It's not typically a hot, like really hot inflammation condition. So some would argue that really the benefit of using nonsteroidals is their pain control, and that the anti-inflammation, yes, when we have acute flare-ups, but that really we're looking to control pain. So long explanation, but I think it's such an important topic that I wanted to do it justice. And I saw, yeah, go ahead, Dr. Cassie. I hope that tackled it.
Yeah, no, that was great. That was a really helpful explanation. And I think what you said may have answered this, but if I can just ask you to elaborate just for my own understanding, everybody else may have a grasp of this already. When we talk about the anti-inflammatory effects of Librela going after NGF, and there may not be enough data to know what the benefits are of targeting NGF and COX mediated inflammation, kind of multimodally, like you said.
Yeah. Are you saying, do we have more information about hitting both of those pathways?
Yeah, whether studied or theoretical, what's kind of the thinking of, because I hear what you're saying with Librela treating the neurogenic type of inflammation. And I guess I'm just wondering, do we know anything about drawbacks or benefits of going multimodally if we're targeting a different type of inflammation with the NSAIDs? And that might be what you were talking about with the chronic inflammation.
Yeah, I think that is a good question. I think we're going to have more information coming soon, both on the anti-inflammatory effects of Librela, which, to be clear, it's not label. It is not an anti-inflammatory. That is not the label for the product. But we should have more information soon about the impact. I think also I go back to the point, which is that yes, inflammation when it comes to arthritis is important and counteracting it. But if you talk to some of the leaders in that space, thought leaders and researchers in that space, they really hone in on the thing that we are trying to prevent and then subsequently we are trying to treat is central sensitization. That is what takes a patient from having pain in one joint to having chronic pain, which is where the nervous system is dysregulated and inappropriately wound up. And so really we're trying to dampen that response and trying to wind down the nervous system. And so again, inflammation, yes, is a part of that, but treating that central sensitization is the goal when we get patients that are truly in chronic pain. So I think definitely more to learn in that space. And one of the best parts about working for Zoetis is that we get to sponsor and do primary research into disease states and therapeutics. So it's really exciting to have. It's kind of crazy. We have a $500 million a year budget for R&D, and it's great. It's fun, I would say.
Absolutely. Yeah, because as I was listening to you, I'm like,
Yeah,
oh, I have so many more
I
questions.
know.
And so
I know.
I'll be really intrigued to see the data
Yeah.
continuing to come out.
Yeah, it's just great. It's great to have better understanding of disease states because it helps us treat our patients more effectively. And speaking of which, I want to, if you don't mind, Dr. Cassie, I saw a comment in the chat about testosterone treatment for
Yeah.
neutered or spayed pets and how I just wanted to acknowledge that attendee. That's really fascinating. I'm going to do a little looking after our call. I'm not familiar with that therapy, but it looks like there's some work being done there. So I just wanted to say thank you for that attendee to bringing it to my attention.
Yeah, I have to echo that as well. I thought that
Yeah,
was a really interesting question,
yeah.
and it complemented this question about a higher incidence of OA and desexed
Hmm.
canines. I think that was what the question was. So those two questions kind of going hand in hand. I went, wow, you guys are really asking some good
Yeah.
questions here.
Yeah, that is a good one. I put the chart from UC Davis. There are some guidelines around age of spay and neuter based on, risk for development of neoplasia, musculoskeletal abnormalities. I'm not certain or aware of a study that has like two populations of desexed and intact animals looking at rates of development of osteoarthritis. I think it would be an interesting study, maybe hard to I don't know. That could be a really interesting study because we know rates of osteoarthritis are so high. It's 40% in the general population. And if you could look at reducing that even by leaving animals intact, but then you of course have to weigh risk of other things. So I think it's a really interesting area of study.
Yeah, yeah, exactly. It's like anything, it's a balance. We want to
Yeah,
do the absolute best by our pets, by our patients, but understanding where that balance is a moving target, and that's a good thing because
indeed.
it means that we're getting more information and we're adapting as we learn more.
Indeed. And Dr. Cassie, I just thought of one more link I'm going to put in the chat pod for
Yes.
everybody. I love how everyone wants to know better and do better. And that is, I saw a comment or a question about fish oil recommendation.
Yes.
And I love that primarily because it's maybe one of my soapboxes, which is that we have evidence for anti inflammatory doses of fish oil providing analgesia for patients with OA. We do not have great evidence to support the use of supplements like glucosamine and chondroitin. And I think many of us, myself included, are possibly doing subtherapeutic doses of fish oil. At least I was in the past. And so, as far as brand, my brand, like just transparently, that I use with my own pets is Nordic Naturals, just because I don't know, somewhere along the way I researched it and decided it was a good quality. However, it's really about the dose. Like you want to make sure, whatever your favorite brand is for purity, but the dose is really the important piece. And I put a dosing chart in the chat from Colorado State University.
Yes.
And what you'll see if you go there is it's a lot higher than you think it's going to be. And I recommend dialing up. So about a quarter of the dose and going up by a quarter every week, GI upset being the primary concern with hitting them with a huge dose of fish oil. But yeah, that's a little bit of a soapbox because so many of us reach for glucosamine and chondroitin. I know our customers reach for cannabis and or CBD oil and whatnot, but like we have evidence for fish oil. It's widely available. Like let's get that on board, or feed a diet that has therapeutic levels, which is potentially easier. Not in my house because I have too many dogs.
Yes, yeah, I know. Mine was on a joint diet for a while, but he has sensitive GI tract, so we had to prioritize his GI over his joints. But yeah, I love that. I use that Colorado State chart myself when I'm trying to dose fish oil, and you're right, it is a really high dose. So
It is.
So important to make sure that we're reaching for the right dose. We're about 10 after, so unfortunately, I don't know that we're going to be able to cover all of the questions, which kills me because these are really great ones. Do you have time for one more?
I do. Yeah.
All right, let's do one. Do you have a preference?
You know what? Oh, here it is. New. Let me management of severe. Let me just peek at it real quickly. Oh, Cartrophin injection. That's interesting. We don't have that in the US, so I'm going to leave that one be. That's a UK product. I find it fascinating. Let me answer a couple of these. So, is it considered disease modifying or symptom modifying? So the answer is it is not disease modifying. There is only one medication currently approved on the market with a D mode is the short name, or a disease modifying claim. Now, not to throw shade because it's a product that I use all the time and have used in my own pet, but the current thinking is if that product went back through approval, it would never get a D mode claim. That is like the holy grail of osteoarthritis therapy. So no, Librela doesn't have a D mode claim. None of the nonsteroidals we use have a D mode claim, which just means literally slowing or stopping the progression of the disease underlying. So yes, it is symptom control, but to be very clear, that is what we're doing with all of our therapies is symptom control. So there is, I'll cede that the label for that injectable product does have the claim, but it's, maybe a little bit challenging. Again, I use it, but we are symptom controlling when we're controlling OA. We answered the fish oil one. Side effects with Librela. I would love to handle that one. And then I think there's a question about ataxia treating with Librela. So maybe we'll finish out with that one, Dr. Cassie.
Sure.
Yeah. So side effects with Librela from a global perspective, the top 3 adverse events reported. So now just to note that adverse events reported don't necessarily equal causation. So I'm going to share the things that are reported most commonly. One is lack of efficacy, which is considered an adverse event. The second is polydipsia, polyuria, ataxia, then polydipsia, polyuria. So increase in water intake and urination. So those are the most commonly reported adverse events, and they are included on the label and the post-approval update label for Librela in the US market. So I think those are the 3 most common. Now, thoughts of managing severe ataxia in hind legs after 2 years of treating with Librela. So my thoughts on that are that there needs to be a thorough neurologic workup for that patient, ideally. So first, reporting that as an adverse event to Zoetis is imperative. So, and actually, if that attendee wants to pop in any information in the chat, or I can actually put the link for reporting that adverse event, because we would love to investigate that further. We do support our customers and support the end pet user when there is a suspected adverse event. So please make sure to call Zoetis and report that. But my thought would be that pet needs a full neurologic workup. A couple of reasons. One, could it be product associated? Potentially. There is yet to be a distinct causal link between Librela and ataxia. I'm not saying it can't be the case, but there is not a clear causal association like we have with PUPD, which is, we believe, a causal link with Librela. And then further, we know that it's around 12% of patients 12 years of age or older, how convenient, have an underlying neurologic abnormality. So I typically advise, let's not take our diagnostic hats off and just go, okay, I put a product in and that's what's causing it. Like this pet ideally would have a full neuro workup to look for other underlying causes of ataxia, which we know increase with age. And I don't know for certain how old this dog is, but the reality is most pets diagnosed with osteoarthritis are late stage. So it's around 10.7 years is the average for a diagnosis of OA. So making some assumptions that it's an older dog and we need to be looking for other things like IBD, degenerative myelopathy, other things that may come up. But first and foremost, report to Zoetis and seek that case support and help. We will provide it. We'll stand behind our products and support our customers and the pet owner. So Dr. Hopkins, if you're out there, make sure to contact Zoetis. I hope that's helpful. I think we did pretty well in questions, Cassie. What do you think?
Yeah, I'm really impressed. I didn't know that we'd be able to get through as many as we did.
Yeah.
You did a great job getting through them. So thank you.
Yeah.
Awesome.
Awesome.
I guess we'll go ahead and wrap up just to be sensitive to everyone's time. Any final thoughts you want to share?
Oh my gosh, I should have thought of this
So
ahead
many.
of time. No, I love it. Thank you for the opportunity first to present this material. I think it's so important that as a profession, we start looking for osteoarthritis sooner. Osteoarthritis comes from developmental diseases. Developmental diseases happen during development, not when dogs are 10 years old. And I speak from a place of passion because I didn't say it in the recording, but Ernest is my dog, the little Ernest that I detailed. And he's been painful since he was probably 2.5. And it's so important we look sooner because we can dramatically improve the quality of life for pets if we look for it and we intervene sooner with appropriate pain management. So that would be my parting thought: is look sooner than you think you need to.
Yeah, I love that. And Ernest, yeah, he makes another appearance on Vetfolio
He
here as
does.
well.
He's the cutest. He's rotten, but he's
Yes.
cute.
Oh, he's so cute. Well, thank you again. Such a great discussion.
Thank
As a
you.
reminder, if you're registered on Vetfolio and you're attending live, no further action is needed to obtain your CE credit. If you're registered on YouTube, be sure and fill out the JOT form provided in the chat. You'll see your CE certificate in your Vetfolio learner profile within 24 hours. This session will be available on demand through Vetfolio in the coming days. Of course, we want to thank you all for joining us. Thank you to Dr. Courtney Pierce for a fantastic presentation. Big thank you to Zoetis for sponsoring today's webinar, and everybody have a great day.
Thanks, everyone.
Bye.